Hi there, my name is Cheryl Crow. I'm really excited to be talking to you today about the role of occupational therapy in supporting people with osteoarthritis. So quick disclosure, I am paid consulting fees by Global Healthy Living Foundation, and who is the parent, a nonprofit of 𝐒𝐂𝐑𝐈𝐁𝐄 and AbbVie for some video consultations. And I also run my own patient education company. And my name is Cheryl Crow. I have been a rheumatoid arthritis patient for 19 years and an occupational therapist for almost 10 years. And I'm also a patient educator and course creator and a lot of other things too. So my objectives for today are for you to understand how occupational therapists help people with OA improve their quality of life through focusing on their ability to function in their specific daily life context, and also understand some common evidence-based OT interventions for OA and the distinct role of OT on the multidisciplinary team. So really, occupational therapists, we're all about the doing of the tasks that are important in someone's life. So participation and performance and action words, verb words are really important to us, and we begin with an evaluation to determine what does the client want or need to do, and how is arthritis hindering their ability to do what they want and need to do. So it's very, very individual focused. And I did say in the description, I was going to talk about the biopsychosocial, which I will, but I also really love the PEO model in occupational therapy, which is person, environment, and occupation, which for shorthand for today, we'll just say is task performance or ability to function. So we have the internal, intrinsic factors that contribute to that, your physical abilities, obviously pain, range of motion, as well as your cognitive, psychological factors, beliefs. And then we also have the specific environment the person finds them in. I think, as most of us know, you can have 20 people with the same diagnosis of knee osteoarthritis, but their context can be either very supportive of their function in life or very hindering. So we look at the person as in the intersection of the person's ability to perform the task is in the intersection between the person and their environment. And again, I love the biopsychosocial model. So it really looks at, what's going on in the body, as well as our thoughts and beliefs and degree of stress, and then our social environment. So when we assess someone with OA, the most important question, honestly, to me is, walk me through a day in your life. What is hard for you? What are the reasons that task is hard? Is it putting on your shoes? Is it, a higher level cognitive task, like maybe managing your appointments, taking care of children or pets or grandchildren? So we really want to first know what is the difficulty? And then we're kind of like a life skill detective, helping the client figure out where is the breakdown occurring and what are the patient's goals? What do they want to be able to do as a result of occupational therapy? And then we also look at, of course, the physical factors in their performance skills, things like range of motion, strength, and mental, cognitive abilities, and then their patterns, what's the day in their life like? What are their weekly, monthly, daily routines? And then how good is the fit between the person and their environment? So some examples, because I think a lot of us learn by example. So an example of an OT goal would be client will use joint protection principles and adaptive strategies while performing gardening, other household activities, and ADLs, which is activities of daily living. In this case, this is directly from the OT practice guidelines for adults with arthritis and rheumatic conditions, and from the American Occupational Therapy Association. Another example is a pain management example of client will use, X strategy, in this case, imagery or progressive relaxation and ice, for pain management during rest breaks and after walking and cycling. So those are just really specific examples. And I'm going to review from that same practice guidelines some of the best evidence-based interventions currently for osteoarthritis in occupational therapy. So we have education and self-management programs to really, improve quality of life and reduce even depressive symptoms and pain, which is really exciting for me. So a simple thing, I really think a picture is worth 1,000 words. So I use a lot of pictures in my self-management education endeavors. So, hey, which one is better? Is it the way I'm holding my baby in this picture or on that picture? And, if you do live in pain, it becomes a little bit obvious at a certain point, but you'd be surprised how often people, they don't, in our daily habits, we don't necessarily have a conscious awareness of the different ways we could approach a simple task that might actually reduce our pain. So some more examples in my mind: legendary occupational therapist Barbara Heilman, she created a gadget called Unbuckle Me, which helps you do a very difficult task if you're taking care of small children, which is unbuckling their car seat. So that's one example. So we really work on modifying the tasks in the client's environment. It could just be modifying the client's approach to the task, or it could be using adaptive equipment. It doesn't have to be fancy. This is literally me using a hair tie as a zipper pull while pulling down a zipper on clothing. Or it could be, dice them, or it could be a special rocker knife, or it could be simply helping instruct them in, hey, using a pump bottle is probably going to be easier for you if you have thumb pain than using a squeeze bottle. And here's why. We also have other specific gadgets and gizmos, and we look at all activities of daily living, everything, from toileting, sex, cooking, everything that someone might do in their life. And with, fine motor skills, we have things like handwriting, of course, and, again, material selection for different tasks. And I've been really surprised in my patient education endeavors how few people actually know about the simple, adaptive techniques out there. So some more evidence for occupational therapy interventions, and this is where we kind of overlap a bit with physical therapy, as I think you just heard from a physiotherapist, but, behavioral interventions to improve taking part in physical activity and reducing pain. There's great evidence for those, and just physical activity in and of itself. So, we all know that, joints in motion, motion is lotion. So that improves quality of life. And when we say occupational performance, we really mean, again, that function in daily life with meaningful daily activities. Specifically, aquatic exercise has a really great amount of evidence for it. And it tends to have high patient satisfaction levels as well. Pain management education includes things like, understanding the science behind pain, understanding, simple modalities you may use like heat or cold, and when to use heat versus cold, compression and other tools for someone's pain toolbox. I found it's really empowering for patients to literally just help them gather a literal box where you can put your different tools and techniques for pain reduction. It's an empowering situation to feel like you have something you can do. And, guided imagery can also help reduce pain and increase quality of life. And Tai Chi, again, Tai Chi kind of also goes under behavioral and activity interventions as well. And this is kind of actually my favorite area, which is the psychosocial and coping focused treatment. So cognitive behavior therapy, has lots of evidence that I have some mixed feelings about it at times, but, and it is helpful. And obviously I have to look at the evidence that, it can be very helpful to look at how your thoughts and behaviors and feelings kind of all interrelate when it comes to pain, and get people out of some of those maladaptive thinking patterns. I just for the record want to say that, pain catastrophizing is a bit controversial because, who is a therapist to say that someone's, thoughts about their pain are too big or too small. But that's what leads me to why I really like acceptance and commitment therapy, or ACT, which is also evidence-based for improving quality of life and decreasing anxiety for people in chronic pain in general, not necessarily just from osteoarthritis. But ACT is not as concerned with whether your thoughts are valid or distorted or not. It's whether they're helpful. So is that a helpful thought or not? And it does, and there's a whole lot of, I could talk about ACT all day long, but I really, as somebody who myself lives in pain and an occupational therapist, I find these two together can be helpful. And especially if CBT is not really working, or you're getting to a ceiling with that, ACT can help too, because it's really it's a mindfulness and behavior approach. And so you start with life as it is in this moment. Yes, that might include pain. And then we say, okay, can we commit to still doing, even if we're not going to necessarily get rid of that pain, can we commit to doing something meaningful, something that brings us joy, or something that is valuable to us despite that pain? It's been really an amazing thing for me and many of the people I work with. And In the big picture, I think a lot of times when clients and patients first start the therapy process, whether it's physical therapy or OT or psychological based therapies, I think I'm speaking maybe just for myself as a patient, but we all kind of just want the pain to go away, right? And like, just tell me how to make it better. But in occupational therapy, we have this little unofficial logo of the OT-REX, and maybe it's more in the US, but the OT-REX is the analogy is, giving someone an adaptive tool so they can function better because the T-REX has really small hands. So, in general, we always have a choice between are we going to try to solve the problem or use a remedial technique, like make your ability better, make your pain better, / reduce your pain, make your pain go away. Or are we going to adapt and compensate? And as you saw earlier, there's quite a bit of tools for adapting and compensating. And it might take a few sessions for someone to get comfortable kind of looking at the compensatory and understanding that at a certain point, we may not be able to get your pain to totally, go away. So I find it helpful. This is actually research from John Gottman, marriage research in identifying solvable versus perpetual problems, and it's similar a little bit to acceptance and commitment therapy, where you accept that some things are not solvable, at least in the present moment. In the present moment, I have this pain. And then you say, okay, can I work around it? Can I adapt with it? While still, and maybe in the future, I can seek some, remedial solutions. This is long. This is too long for a 15-minute talk, but I did develop this, just putting the bug in your ear. And if you're watching a recording later, you can like hit pause. But along the lines of the idea of the solvable versus perpetual problems, I developed this schematic, chronic pain stress decision helper, and to help you figure out, okay, if you have a solvable problem, let's say I'm in a lot of pain and I want to feel relief. Well, first of all, okay, you have a problem. I'm in pain and I want to feel relief. First, you ask yourself, is it a thinking problem? Because that's where a lot of the CBT stuff comes in. Is if it's something where I could change how I think about it and the problem would get solved, then we want to do reframing and CBT tools. But in this case, no, it's not a thinking problem. I don't want to change how I think about it. I want to try a pain relief tool. Then you say, is it solvable or persistent? Well, maybe it's slightly solvable. I can use a heat pack. I can use my medications, meditate, talk to a friend. So it's like helps people think through the kind of overwhelm that often comes with the experience of having pain. And then we can say, okay, what about an example of a persistent or unsolvable problem? And that's where we kind of get the thoughts about the future. Oh my gosh, I'm overwhelmed. Like, what is my future going to be like? I can't live like this. I'm really stressed by the uncertainty. And then, I can't think differently. I mean, technically, yes, you could do both, thinking tools and and you could do mindfulness tools. But really, in this case, I'm just going to say, fundamentally, you're not going to solve the problem of uncertainty. It is just a reality that we have to kind of confront and accept. You could try every single different thing in the world to think differently about it. But at the end of the day, there's no one that could really give you true certainty in life. So then you say, okay, this is reality. Is it solvable or persistent or perpetual? It's persistent. Okay. So then we use our coping tools to say, this is not going away, but I can cope with it and I can thrive despite it. And I know, again, you're probably thinking, wait a minute, this is like, OT is such a funny profession. Like, we think we're like kind of a bridge. No one ever really says this, but this is just my opinion, that we're really kind of a bridge between physical therapy or physiotherapy and psychological support, because we do have that, grounding in the, the physical, anatomy, physiology, but we also have our roots in mental health. Occupational therapy was formed in 1917 when soldiers were coming back from World War I with, shock, and I forget what it's called, but they were, mentally very unwell. And we used daily activities and activities like basket weaving and all sorts of things. Anyway, that's a whole long other story. But, the line between occupational therapy, physical therapy, or physiotherapy and psychological services is going to be drawn differently in different settings. And that's just reality because it's kind of messy how everything has evolved over time. So sometimes you'll see occupational therapists that are like not actually doing the mental health part I just talked about. But just so you know, that is in our scope of practice. And that is kind of the heart of our profession, is looking at both the minutia of like what's happening to your muscles and your thumb, and then looking at the big picture of like, how do you feel about that? How is that affecting your function in daily life? And so, if I could rename our profession, I would call us life skills therapists or life skills specialists. We're kind of like a PT, a psychologist, and a little bit like a life coach. And again, we do have, I will say, I'm the first to admit, our profession has sometimes a little bit of the jack of all trades, master of none issue. But I am very proud and happy to be an occupational therapist. And it's a little messy, but I love it. And I found that so many patients find it a breath of fresh air that somebody just really wants to like go through in maybe a little bit of excruciating detail, but the minutia of their daily life and helping them function better. So, the ability to kind of see the physical and the mental well-being is something that I am proud of as an occupational therapist. So here's some references and citations, and this is how to get a hold of me later. I'm happy to answer more questions live in the Q&A section soon. Thank you so much for your time.